Dear students, welcome to Bluepen Online. Shall we begin? Please use headset, pen and paper to take notes.
Here you go. Please let's know your feedback after class.
Welcome to Bluepen Online classes. Myself, Dr. Anu, and today we will be dealing with the topic Preventive and Intersepetive Orthodontics. So, first of all, both these terms are entirely different. Okay, preventive is something else, interceptive is something else. So, what's the difference between preventive and interceptive? Preventive is something that you take in anticipation of development of a problem, okay, before the problem. And interceptive is something that we do when the problem is already there. Okay, so that's the difference. Preventive is something that we do before that problem. Like in the anticipation of development of the problem, we'll do the preventive thing. Interceptive is like it's already there. The problem has already occurred. Now you have to clear it. Okay, it's just started. For example, I will give an example. So, suppose there is a supernumerary teeth. Okay, supernumerary teeth, and this teeth is causing some displacement of some other teeth. Okay, so it is resulting in some displacement, and you can see a malocclusion from this. If you see the malocclusion from this, and now you are going to treat this, it's an interceptive procedure. But you came to know about it is like a supernumerary teeth. Now you know it's a supernumerary teeth, and you have to remove that teeth before it causes some malocclusion, and that as a preventive. So that's the difference between a preventive and an interceptive kind of treatment. I hope it's clear. Then, okay, so yeah. This is the definition for the preventive, the actions taken to preserve the integrity of what appears to be normal at a specific time. Okay, so here what all we'll have the patient education, parent education, then patient's education is also there, but parent's education is very important. Okay, because these all are kids, and we do this in the digital education period, so parent influence is very high, right? So parent education, patient education also. Then supervision of growth, development of dentition, craniofacial structures, diagnostic procedures undertaken to predict the appearance of a malocclusion, treatment procedures instituted to prevent the onset of malocclusion. So these all comes under what? Preventive orthodontics. So what I've told is the first slide, the anticipation, and when it is already there. Okay, both are done in mixed and deciduous dentition. 3 to 12 years of age, this is when you do this. See, now coming to the advantages, I think it's not that clear. Okay, so I will tell you. So coming to the advantages of the preventive orthodontics, you have first as intervening in deciduous dentition simplifies the treatment in permanent dentition. Right, you are correcting it in deciduous dentition, so that this will simplify the treatment that you want to do in the permanent dentition if it goes like this. Okay, then what? Better compliance is possible at the younger age. Better stability will be there for the treatment. Better use of growth to aid the treatment. You can use that growth to aid the treatment, right? The child is in the growth stage. So you can use that growth to aid the treatment. Pathology such as root resorption may be avoided. Okay, possible to avoid orthodontic surgery at a later age. Okay, improved aesthetics due to intervention at an early age. Possible to avoid psychosocial problems associated with the malocclusion. So all these things you can do with a preventive malocclusion. So all these things are advantages of your preventive orthodontics. I'm sorry, I've missed it. It's preventive orthodontics. Now coming to the disadvantages. What will be the disadvantages? See, actually preventive orthodontics is something really good, but there are some opponents that actually put forward some disadvantages, like there's a chance of relapse at all. Okay, then growth prediction is unreliable at an early age. Lengthy treatment plans can result in cooperation burnouts. Care can be big, carry, then increased course of treatment, root resorption. These are all some disadvantages that are actually put forward for this preventive, but preventive is good only, as you and I know that. It's good only. You can prevent that in an earlier stage, means really good, right? Now, first thing. What do you do first in a preventive orthodontic treatment? It's an education thing. You have to educate the patient. I mean the parent first. Okay, so it's like what mothers should be educated on proper care and nursing of the child in nursing. You know what it is. The use of the feeding bottle, the nipples that they use, we are conventional and physiological one. So there's a difference between the physiological and the conventional one that I will tell you. In case the child is being bottle fed, yeah, that's what I told. Physiological nipple and not a conventional nipple. Use of pacifier. Nursing board KDs, you have to take care of that also. Maintain all good oral hygiene and proper method of pressure. These all are something that you should tell mother. The child is really in a very small age, so parents have to help the child. So that's the reason why we have to educate the parents first in this stage, the diseases and the mixed stage. Okay, coming to the next slide, you can see some nipple here. This is physiological nipple and this is conventional nipple. Okay, so if the child is being bottle fed, the mother is advised only to use the physiological kind of nipple, this one, because physiological nipples are designed to permit suckling of the milk. That is, more or less, it resembles what? Normal functional activity as it is in the breastfeeding. So that's the reason why we always recommend to use the physiological one. Okay, but the conventional are non-physiologic and they do not permit the suckling at the movement of the tongue and the lower jaw. Okay, so if the child uses this conventional kind of nipple for a longer time, what can happen? They can lead to various orthodontic problems of the teeth. That's the reason why we always recommend to use what? Physiological nipple over conventional one. And also, what are conventional pacifiers? These are pacifiers. Even we tell the young mothers to reduce the use of these pacifiers. You know why? This is having a detrimental effect on the dentition. That's the reason why we tell to maximum reduce the use of pacifiers. Okay. Now coming, this is how it is. This is the physiologic and the conventional. Just see the difference between them. Okay. Now, caries control. Now in caries control, caries involving the proximal surface of the deciduous teeth, if they are not restored, that can result in loss of arch length by movement of adjacent teeth into that space. Okay, if this is a deciduous tooth and there was a carie and you haven't restored it and that is completely decayed, okay, you have to restore it. Otherwise, what can happen? The adjacent teeth, which is adjacent, will actually take that place. Okay, if some mesial movement like that happens, this results in discrepancies when the permanent come into place. So if there is any caries, please restore it as soon as possible. Caries detected by clinical and radiological examination. This is how we do it. Caries should be detected in this way. Biting radiographs can also be used as a valuable aid in detection of caries. Okay, once you detect that there is a carie, the next step is you have to do the proper restoration immediately. Because if you delay it, okay, delays can result in what? It can result in loss of arch length. So you have to be careful about it. See mesodistal caries leading to loss of arch dimension. Okay, now care of deciduous dentition. See, through prevention and timely restoration of caries teeth, this is something that I have told in the last slide. Okay, caries control. Okay, now the next thing, excellent natural space maintainers. Deciduous teeth are the best space maintainers. Why do you call it as a space maintainer? They are maintaining the space until what? Until the permanent, that's why you call it what? As a space maintainer. Okay, so you have to make sure that you have to put all effort, okay, to make sure that there is no early loss of deciduous teeth, because they are the best space maintainer. You have to keep it there. So you can, if there is any caries, remove and restore it. If there is a chance of caries happening, you can put the Peter and Fisher sealants there, right? Topical fluoride application can also be done. These all are done in a preventive measure as a method of preventing what? Caries. Now, let's see what I told now. Then what? Extraction of supernumerary teeth. This is something that I've explained during the definition time. So Extra teeth, you know what is a supernumerary teeth? They are extra teeth, right? They are present in addition to the normal complement of teeth. So it's an extra one. Okay, if the child is having these many teeth, if one is seen as an extra, that is a supernumerary teeth. Okay, this is more common in permanent, but also in diseases you can see some. Okay, it can also occur. They are more commonly seen in males and it's more commonly seen in maxilla. So if you find that there is supernumerary teeth, it's better to remove it because then only the teeth can erupt normally there. Okay, sometimes may not be able to erupt on its own due to the position or lack of adequate space. Sometimes they will be inside only. They will not have a space to come out. Okay, then surgical exposure or orthodontic traction may be required in many cases. Okay, and this can cause crowding, this can cause displacement, this can also cause work spacing. And very rarely cystic formation is also seen with what? Unerupted, not erupted, with the unerupted supernumerary teeth. Okay, so this is the case of supernumerary. You can see the supplemental lateral incisor. Okay, and you can also see how crowding is happening there. Okay, the supplemental lateral incisor, not the amount of crowding seen in this. Now, presence of supernumerary teeth has resulted in delay in eruption of the maxillary, lateral and maxillary incisors here. Now, here you can see the mesiodense in between the central incisors. So, these all are about supplemental teeth or the supernumerary teeth. Now, elimination of occlusal interference. If there is any functional prematurity, they should be eliminated because they can cause what? They can deviate the mandibular pap closure. And also they can lead to what? They can lead to bruxism. That's the reason why if there is any functional prematurity, please remove it. Okay, like enamel pearls or something. If there is enamel pearls, there can be a premature contact happening there, so you have to remove that. Presence of large cingulum and maxillary incisors prevent normal overbite and overjut. Okay, so it's like you grind it. This should be eliminated by grinding. Okay, like kind of selective grinding can be carried out there. Okay, so if there is a presence, see, it's a very common thing to see this large cingulum on a maxillary incisor. This can prevent the establishment of normal overbite and overjut. So these are some problems you had to eliminate that if some kind of problems are there. Like, okay, so this is note and presence of large cingulum on maxillary incisor prevent normal overjut and overbite. So you have to eliminate these kind of what? Interferences. Then what? See enamel pearls here, right? See the large cingulum. So imagine something like this. When you close, this can alter what? Normal overjut and normal overbite. That's the reason why you have to grind it. Okay. Now maintenance of tooth shedding timetable. See, if there is a more than 3 months of difference between the shedding and of shedding of the disease and eruption of permanent, you have to take care of it. Okay, there should not be like more than 3 months between them. Okay, so if there is any delay, mostly it will be like they can be ankylosed primary baby teeth, fibrosis of gingiva, overhang restoration, cyst tumors, supernumerary, presence of unresolved deciduous root fragments, presence of over-retained deciduous teeth. Any of this can be the reason. Okay, so if the delay is because of what? Because of a supernumerary or an unresolved root fragment, if these are the reasons, you can solve it by removing that course. Okay, now if it is an over-retained deciduous teeth, sometimes lead to what? Ectopic eruption also. So you have to take care of this. The tooth shedding timetable should be correctly followed. Now what? Ankylosis. Now what is ankylosis? You all know what is ankylosis. What is ankylosis? See, this is a tooth, this is the root. What is here? You have cementum. So here what happens is, usually you have PDL, right? In ankylosis, you will not have this PDL. So it's like cementum and bone directly fuses. So that is ankylosate, and so that it will be immobile. You don't have that PDL. So it's direct fusion between the tooth root and what? The bone. So it's immobile completely. So mostly this is smaller, tooth appears upmost or intra-occlusion. It will be like an intra-occlusion. Okay, this is like 7 to 14% seen in primary dentition as a result of congenital absence of permanent successor, failure of resorption or trauma or infection. These all are the reasons for what? Ankylosis. Okay. Now, angular teeth do not get resolved. The deciduous one will never get resolved. Okay, so prevent the permanent from erupting. So this will also be here. The permanent one will also be here. This is how it is. They can deflect or deflect them from erupt in abnormal occlusion. They can make them erupt into some other occlusion other than its normal and correct place. Presence of deeply submerged tooth can cause tipping of adjacent teeth and possibly supra-eruption of the opposing teeth. Okay, that can happen. Extraction, prolonged retention, marginal discrepancies. Okay, these all are what you can do. Okay, in case of absence of underlying permanent tooth, a decision should be made as to extract the tooth or build up the vertical dimension of the tooth and retain it. Okay, this is actually decided on the health after seeing the health of the tooth and its periodontal condition only. You will see what is to be done. So this is only what you want to know about the angular teeth. Okay, again, absence of underlying permanent tooth, extracted. This is what I have told you based on health of the tooth. Same thing, what I told you just. See, you can see the ankylosed one here. Primary, second molar, and infraocclusion. Okay. Now, if there are some abnormal frenal attachments, okay, this is like what is frenum? You know what is frenum, right? It's the presence of thick fleshy. You can see that thick fleshy maxillary labial frenum. If it is attached relatively low, this will prevent the maxillary center incisor from approximating each other. So there will be a gap, and this is known as what? This is known as midline diastema. So there is high chance of midline diastema in these kind of cases. So this is the kind of abnormal frenal attachment. Okay, and mostly this comes with the hereditary factors, and you can treat it in the early age. Diagnosis is a blanch test. This is how you diagnose. Okay. Now, notching of the interdental bone, thick frenal attachment. In addition, notching of the interdental bone in periapical radiograph confirms a thick frenal attachment. In what? Periapical radiograph. You see notching of the interdental bone in the periapical radiograph. It shows that there is a thick frenal attachment. Okay. See. Now this is tongue tie. You know what is tongue tie? Tongue tie is ankyloglosia. Okay, this results from what? The lingual frenum extending further than usual towards the tip of the tongue. This is extended to the tip of the tongue. So what happens? This will limit the movement of the tongue. Forward and upward mobility will be limited here. This is also kind of hereditary only. Okay. See, given here. Lingual frenum. Yeah. Okay. Breastfeeding problem will be there. Okay. Then prevents normal functional development. Abnormalities will be there in speech while swallowing. So you can go for a surgical treatment. Okay. Mainly when the patient is having this kind of ankylosing spondylitis, they will be having problems with the sounds T, D, T, S, K, T, D, S, T, H, okay. So all these sounds will have some problem. Okay, so this condition should be what? Surgically treated. Okay. Then oral habits checkup and educating patients and parents. Okay, you have to see whether the patient is having some kind of habit. Okay, like what? Finger, thumb sucking, nail biting, tongue twisting, lip biting. So if something is there, you have to identify and stop it at an early age. Okay, now proper nursing, you have to take care of that also, because it is prevention should start with the proper nursing, right? And as I told you, should use what? Physiologically designed nursing nipple over what? Conventional one. And also, pacifier should not be used for an extended period. Okay. Then preventing Milwaukee brace damage. You know what is this Milwaukee brace? Have you heard about scoliosis? So this is something that is given for the scoliosis patient. This is an orthopedic appliance. I think I have the picture. Yeah, this is the Milwaukee brace. So as you can see in the picture, this appliance is exerting a lot of pressure on the mandible. Okay, this is exerting tremendous force on the mandible and the developing occlusion. So there is a problem. What happens? there is retardation of the mandibular growth here. And possible deformities can also happen. Okay, so whenever these kind of appliances is this particular appliance is used for scoliosis, occlusion should be protected using functional appliances or positioners made up of soft materials. You have to take care of it. Okay. Then deeply lobed permanent first molars. Okay, the deciduous second molars occasionally have a prominent distal bulge. Okay, a kind of distal bulge. This is the deciduous second molar. This is prominent. A distal bulge is more common. So, if there is such kind of a distal bulge, this will prevent the eruption of the coming first permanent molar. It will be like this. So, if it is like that, you will slice this part. So, it will be like this, and it will be fine to erupt. This deeply low permanent first molar. I have a picture, I'm sorry. See, bulge, you will remove the bulge now. Eruption. Okay, now coming to the space maintainers. Now, what are space maintainers? Which are the best space maintainers? Something that I've shown in the first page, like the first slide. How the best space maintainers? Yeah, deciduous, right? Now, by some course, this is previous to the okay, there's a space that you have to protect. There you use what? A space maintainer. Okay, so they should maintain the mesiodistal space created by low teeth. Okay, they should restore the function. Okay, as far as possible, and prevent over eruption of the opposing teeth. They should be simple in construction. They should be strong enough to withstand the forces. They should not exert excessive pressure on the adjoining teeth. They should permit maintenance of the oral hygiene. Must not restrict the normal growth and development and natural adjustment that takes place during the transition from the deciduous to the permanent dentition. These all are some requirements. Now coming to the classification, Hitchcock classification, you have removable or fixed or semi-fixed, with bands, without bands, functional, non-functional, active, passive, and some combinations of the above. And according to Raymond Stroh, you have removable, complete arch, lingual arch, and extralingual arch, individual tooth. Okay, in Henderson, you have class 1. And class 2 and class 1 you have this. Okay, non-functional type, bar type, loop type, functional, pontic, lingual arch, class 2 is cantilever type. Okay, removable space maintainer, you have acrylic partial dentures. Okay, so these are some classification, study some classification because you can sometimes get a question on classification. Now, factors governing the selection of the appliance, first and most important, patient cooperation should be there, for sure, right? Then what? Then appliance integrity, maintenance, modifiability, limitations and codes. These all are what? Some factors that should take care. Okay. Now coming to the next slide, starting with the removable space maintainers. Now, by the term you know what are these removable space maintainers. Do you know what is an RPD? That's a removable partial denture. Now, what will be the removable space maintainer? You can remove it like what we do in an RPD, right? So they can be removed and placed by the patient himself or herself. So they can be functional and non-functional. Functional actually helps in what? Mastication, speech, and aesthetic. Non-functional have only that acrylic extension over the edentulous area, just the acrylic extension. They will not have any teeth over it. So this is just this acrylic extension, the only thing is to close the space. If there is a tooth in over this acrylic plate, that means that what? They are used as a functional one. They are used for what? They are used for mastication. Then comes the functional removable space maintainer. Okay, now indications of the removable space maintainer. Aesthetic is important. We can use that. In case of abutment teeth cannot support a fixed appliance, then you can use that. Cleft palate patient who require obturation of the palatal defect, you can use that. In case a radiograph reveals that the unerupted permanent tooth is not going to erupt in less than 5 months' time, a removable space maintainer can be given. If a permanent teeth have not fully erupted, okay, multiple rows of deciduous teeth that may require functional replacement in the form of either partial or complete denture, then also you can use what? Removable space maintainer. Contraindication, definitely, if the patient is not that cooperative, you can't use it. Who are allergic to the acrylic material, and also epileptic patients who have uncontrolled seizures, you can't use it. There's high risk because this is a removable one. You'll get removed easily. Now, advantages, they are hygienic, as you can clean it when you compare it with the fixed one. Vertical dimension is maintained. If there is a tooth, that will be maintained, that vertical dimension. Part-time wear allows blood circulation in the tissue. aesthetic, phonetic, mastication is also possible, tongue is kept in bond, stimulate eruption, band construction is not required, caries detection is very easy, modifiability can also be used in combination with other preventive procedures. So these all are some advantages. Now, what are disadvantages? Can easily be lost or broken. If it's broken, it's gone, right? Now, jaw growth restriction leading to crow's bite. That's an issue. So it will keep that space like that only. So there is a restriction like that. To prevent jaw growth hindrance, either change the appliance periodically or remove the molar clasp and make anterior retention of spurs. That's how we can solve it. And also it may irritate underlying soft tissue. So these are some disadvantages. I know this is very simple. Just to read, you will understand everything, but still I'm just repeating it. Okay. Some commonly used removable space maintainers. For the first one is the acrylic partial denture. That's the same RPD thing. Okay, who had multiple extraction, you can use that. Okay, that will completely restore the masticatory function also, just as your RPD. Think your RPD here. So you will put the clasp also either on what deciduous canines or molars for the retention. Then full or complete denture. These denture help in masticatory function and aesthetic, also guide first molar into the correct position. Okay. Then fixed space maintainer. So these are like completely fixed or fixed. Okay. Now here you have band and loop, crown and loop, lingual arch and palatal arch. These are the types of fixed space maintainers that you have. Then you have transpalatal, distal shoe, aesthetic anterior space maintainer, band, bolted space maintainer. Let's see. See, this is band and loop, most commonly seen. Okay. See, as the term suggests, you have a band, you have a loop. That's it. Okay, so if here you have a extraction space, the tooth that is present distal to this extraction space is banded. Okay, and a loop of thick stainless wire is soldered to it with its mesial end, this end touching the tooth mesial to the extraction space. So this can be used as a unilateral appliance indicated for the space maintenance in the posterior segments when a single tooth is closed like this. Okay, that is a band and loop. You can use in prematurely loose of primary first molar, where the unerupted premolar is 2 years from clinical eruption. So it's like it wanted to be erupted in next 2 years, but it's gone, like the predecessor is gone. So you have to put a space maintainer. In that case, you can use a band and loop. Okay, and the roof length is less than half. Then contraindication, extreme crowding, space load, and high caries activity. Now coming to crown and loop. So the only difference is that there you had a band and now you are having a crown. That's it. So you are just using a stainless steel crown over the abutment. So this is indicated when this abutment is highly carious, or it is hypoplasia is there, or if it is pulpotomized, you can use a crown and loop on. Then lingual arch. See, this is lingual arch. This is the most effective one when you use in lower arch. Okay, this is lingual arch. That's the reason lower arch. Okay. See, you have two bands on either of the molars. Okay, it can be the first permanent or it can be second deciduous. And these are joined by what? A stainless steel wire like this, connecting all wires, the lingual surface of the four mandible incisors like this. It will go like this. So if there is a multiple rows of primary molars, you can use this. Okay, this will maintain the arch perimeter by preventing both mesial drifting of the molar and also lingual collapse of the anterior teeth. So this will prevent this movement of the molar, and also the lingual collapse of the anterior teeth. Okay. Now palatal arch, same to that of your lingual arch, we also have palatal arch appliance. Like what? See, transpalatal. Here what you do? You're trying to stabilize these first permanent molars. You will band it and you will connect it to the palate. Okay. This is mostly seen when one side is intact. See, this side is intact. The only problem is with this side. So this is most commonly used in these kind of cases. When one side is intact and the other side is having problem. See, unilateral. Okay, contraindication, bilateral, don't use it. Limitation, may cause both the molars to stick together. There is a issue like that also. Then distal shoe space maintainer. This is distal shoe. See, this is also known as intra-alveolar appliance, and this is a very commonly asked question. See, the distal surface of the primary molar guides the unerupted first molar. Okay, see, this is the deciduous fourth, and there was a deciduous second molar, but it is not now. Now it is not here. So if there was a teeth like this side is the one which is going to guide this first molar to come into its position. But unfortunately, the tooth is not here. It is missing. So in that case, you take an intra-alveolar appliance. Okay, and this is how you extend it. Okay, 1 second. Okay. When the second primary molar is removed prior to the eruption of the first permanent molar, you use the distal shoe space maintainer. Okay, because this provides greater control of the path of eruption of the unerupted tooth and also prevents what? Undesirable mesial migration. When this comes, this can go in a mesial migration. We don't want that. That is undesirable. So, in order to prevent that, you can use this. Okay. Now, indication. You can use this when there is the early loss or removal of the second primary molar, even prior to the eruption of first permanent molar. Okay, now contraindication for patient for parent cooperation congenitally missing first molar. You can't use it because what? If there is no first molar, you don't want to use it. You are using this to just guide your first molar, right? No requirement. Medical conditions and also inadequate abutment due to multiple loss. These are the contraindications. Now, limitations. Overextension causes injury to the permanent tooth, but as you know, there is an overextension like this in giant. So, if there is an overextension, there is an extension. If it is an overextension, there is high chance of damaging the permanent tooth but inside. If underextended, what happens? This have to go to an extension. If it is underextended, it may allow what? Molar to tip into the space over the band. So, you have to take care in both the ways. Okay. Now, prevents complete epithelialization of the extraction socket. Then, aesthetic anterior space maintainers. You also have anterior space maintainers, right? This is having a plastic tooth that is fixed onto the lingual arch. That in turn is attached. You can see that, right? An aesthetic component. Now, this is band and bar. You can see there is band on both the teeth and connected by a bar. That is band and bar. Okay, alternatively, you can use a crown also over this in the place of this band. Okay, this is band and bar. The other one is crown and bar. Now, this is preformed bonded space maintainer. There's a direct bonded space maintainer that consists of two bonded mesh pads that are bounded to the teeth on either side of the loose tooth. See? Okay, one of the bases has a metal rod while the other one is having a metal tube. See, here is a tube and here is a rod, and this rod is inserted into the tube and is crimped so that they have required length of the space maintainer. Now you will bond it on the either side. So one is having a tube, other one is having a rod. Rod is placed inside the tube and you will crimp it according to the required space. Okay, now this is lingual arch wire. There is a bilateral loop of the posterior teeth. You can use this. Okay, minor movement of the anterior teeth and maintenance of levious space and space beginning. You can use it. Okay. Then limitations, loss of cementation and solder. These are seen. May cause untoward movement. These all are some limitations. Nothing interesting there. Now coming to the Nance palatal. See, this is a Nance palatal arch. You can see that button over there, right? That is your Nance palatal arch. Okay. See, bilateral lows of deciduous molars. You can use this. Okay, this is combined with a habit breaking appliance on the acrylic button. Okay, then contraindication, if there is any palatal lesion here, you can't use it. If either of the molars has not erupted, you can't use this because you need both of these molars for the help. Okay, and this can also cause tissue hyperplasia and infection due to poor oral hygiene if it is placed like that. Okay, now fixed space maintainers. These all are the ideal properties of the fixed space maintainers. They will preserve the space. Okay, eruption of the adjacent subcutaneous and the permanent teeth, they will help, right? Restoration of masticatory function, prevention of over eruption of antagonist, compatibility with the soft tissues, and effective hindrance of torque forces on the abutment teeth, economy of construction and resistance to distortion, allowance for the adjustment or minor repairs, universal application. So these all are what? These all are the ideal properties of fixed space maintainer. Now we have some advantages. So according to Moyer, there is easy manipulation, there is no huge passion required, ideal for uncooperative patients because you can give this removable thing for the uncooperative patients and also those who those who have what epilepsy, who have recurrent seizures. So and also this fixed bond will last longer than the removable one, right? And that will be more effective. Now disadvantages, requires complex instruments and skills to fabricate this. Okay, and also the tooth which is banded, there is high chance of decalcification. And also because of the torque forces on this abutment, there can be some unwanted movements resulting from that. So these are some disadvantages of what? Fixed space maintainers. So these comes into your preventive dentist, preventive orthodontic dentist. Okay, now coming to the interceptive one. Interceptive is something that is like already there. You are trying to solve it like. Okay, now here the most important one is what? The most important one is always your serial extraction. Okay, also you have what? You have the developing growth by anterior growth by corrected, interception of the habit, space regaining. These all comes under your what? Interceptive orthodontics. But in serial, but the most important thing here is the serial extraction only. So what is in serial extraction? You know what is serial extraction? So it is a planned and a sequential kind of extraction of teeth. Okay, so as to intercept a developing arch length deficiency in order to avoid the need of extensive orthodontic procedure. You are in prior removing some teeth in order to prevent coming malocclusion. Okay, so indication like absence of physiological spacing, you can go for this ectopically erupted teeth, medial migration of the buccal segment. Okay, you can only do this in the skeletal class for malocclusion with a straight profile. And also, if the growth is not enough to overcome the discrepancy, you can use this. Okay, Prophet also said that if the tooth size and arch length discrepancy of 10 mm or greater, you can give it for serial extraction. And the other one said if the discrepancy is of 7 mm and more, then also you can go for serial extraction. So there are two things as I said for the same procedure. Contraindication, you can't use this in the class 2, class 3. You can't use this in the class space addition because if the patient is already having space and you are again creating a space, that don't sound good, right? Anodontia, oligodontia, deep bite, open bite, mild arch length discrepancy, these are all cases, these are contraindicated. Now coming to the procedures, here you have 3 procedures to do what? To do serial extraction, starting from what? Duell's method, then you have Tweed's method, and you also you have Nant's method. Okay, in Duell's method, I'll show you the picture. See, this is a Duell's method. Okay, this is a 3-step serial extraction procedure. Just 3 steps. 1, 2, and 3. Okay, in the first step, what you do is you will extract the deciduous canines. Okay, so when these 2 canines are removed, these incisors will get enough space. Okay, this is carried out when? In 8 to 9 years of age. Now, after 1 year, okay, after 1 year, you will come to the next stage. Here, what you do is deciduous first molars you will remove. Okay, so that the first premolars will come soon. Their entry is accelerated. Now, when these first premolars come, you will remove that also to permit both You extract the erupting forced premolars to permit what? To permit the permanent canine to come into the place. This one. So this is the first method, that's the Duval's method. Okay, now coming to the Tweed's method. Tweed's method is like you will extract the deciduous first molar first. Okay, and then you will go and remove the premolar and also deciduous canine. And the same thing repeats in the Nance method. This is similar to the Tweed's technically and involves extraction of deciduous first molars followed by extraction of the first premolars and the deciduous canine. So this is what happens in the Nance method. Okay. Also, you have something else in interceptive orthodontics, like what you have for the developing anterior crus bite. They should also be intercepted and treated at all, like an earlier age, right? So you have to treat it. Okay, you have what all types of anterior crus bite. I will just rush through this topic. You have dental-alveolar kind of anterior crus bite. You have skeletal anterior crus bite. Also, you have functional anterior crus bite. Okay, if it is a dental alveolar crus bite, how can you treat it? Dental alveolar, you can treat it like what? You can use the tongue blade. Okay, then you can use Catalan. Then you can use double cantilever springs with posterior bite plate. These all are used in dental alveolar anterior crus bite. The functional anterior crus bite. Okay, if there is any occlusal prematurity, you have to clear that. If it's skeletal, you can use what? You can use myofunctional, or you can also use orthopedic appliance. Okay, now coming to the interception of habits that happens in the interceptive orthodontics. So if it is a thumb sucking, how do you do it? It is quite normal if it is till 3 years, but if it is after 3 years, you have to correct it. So these all are in what? Your habits chapter. Tongue thrusting, mouth breathing, all of this. Okay, so this comes in your interceptive orthodontics. So I hope preventive and interceptive orthodontics is now clear for you. If you have any doubt regarding any of these topics, please feel free to ask us. So this is all for now. Thank you.